The hospital's executive conference rooms sparkled with holiday decorations as St. Mary's Medical Center hosted its annual Christmas party for senior staff. Doctors, nurses, and administrators mingled beneath twinkling lights, celebrating another successful year of saving lives and advancing medical excellence. I sat in the corner near the windows, fighting the persistent headaches that had been my constant companion for 3 months, watching my family hold court among their medical colleagues. My sister Dr. Victoria Chen commanded attention at the center of the room, her surgical scrubs replaced by an elegant cocktail dress that reflected her status as the hospital's youngest cardiothoracic surgeon. At 34, she'd built a reputation for precision and excellence that made her the pride of our medical family. The respect in her colleagues' voices was genuine. Victoria had earned her position through years of rigorous training and exceptional skill. Dad stood nearby, accepting congratulations for his recent appointment as Chief of Emergency Medicine. Dr. James Chin had spent 25 years building St. Mary's Trauma Program into one of the region's most respected emergency departments. His expertise had saved countless lives, and his leadership had elevated the hospital's reputation throughout the medical community. What made the evening surreal was that both of them had been systematically dismissing my increasingly severe neurological symptoms for months while accepting praise for their medical expertise from colleagues who had no idea they'd been ignoring a medical crisis in their own family. "Emma's here tonight," Victoria announced to the group of surgeons surrounding her, gesturing toward my quiet corner. "She's been having some headaches lately and making quite a production about routine medical appointments. You know how some people dramatize minor health issues." The casual dismissal landed like a slap across the room. Dr. Patricia Morrison, the hospital's chief of neurology, looked in my direction with professional interest. "Headaches can be concerning depending on the presentation. Has she been evaluated properly?" "Oh, she's been seeing doctors," Dad interjected with the practiced patience of someone explaining a recurring family problem. "Multiple specialists, actually. But you know how it is with certain personality types. They interpret normal diagnostic procedures as major medical events." The characterization of my 3-month odyssey through neurology consultations as normal diagnostic procedures was so disconnected from reality that I almost laughed. The MRI scans showing a growing mass in my frontal lobe weren't normal. The seizure episodes that had started 6 weeks ago weren't normal. The cognitive changes that had begun affecting my work as a research psychologist weren't normal. But to my medical family, they were symptoms I was exaggerating for attention. "Emma works in psychology research at the university," Victoria explained to her colleagues, her voice carrying the subtle condescension reserved for non-medical family members. "She analyzes behavioral data and writes research papers. Not exactly high-stress work, but she's always been prone to anxiety about health issues." My work as a senior research psychologist at the university's Neuropsychology Institute involved studying cognitive function in brain tumor patients, ironically making me more qualified than most people to recognize my own symptoms. But my family had always treated my psychology career as less legitimate than their medical specialties, despite my PhD and published research in major neuroscience journals. "Psychology research," Dr. Morrison repeated thoughtfully. "That actually requires significant neurological understanding. Has anyone reviewed her symptoms from a neuropsychological perspective?" Before I could respond, Mom joined the conversation with her characteristic ability to redirect attention toward family harmony. As the hospital's director of nursing, Dr. Linda Chin had spent 15 years managing critical care units and training nursing staff in emergency protocols. "Emma's always been our sensitive one," Mom explained with maternal warmth that masked clinical dismissal. "She tends to overthink medical situations and interpret routine testing as something more serious than it is. We've learned to provide support while maintaining perspective about what constitutes genuine medical concerns." The description of my brain tumor symptoms as overthinking routine testing was so medically irresponsible that I wondered how my family reconciled their professional expertise with their complete failure to apply basic diagnostic principles to their own daughter's condition. "The imaging studies have been inconclusive," Dad added with the authority of someone who hadn't actually reviewed any imaging studies. "Sometimes anxiety manifests as physical symptoms that seem more serious than they actually are." What he didn't mention was that my MRI reports had been sitting in his email inbox unopened for 2 weeks. The neurology consultations he'd dismissed as unnecessary had resulted in urgent referrals that he'd never bothered to acknowledge. The brain tumor that 3 different specialists had identified was apparently less important than maintaining the family narrative that I was prone to medical drama. Tomorrow they'd learn exactly what their medical colleagues thought about healthcare professionals who ignored documented brain tumors in their own family members. The week following the Christmas party unfolded with the same disturbing pattern that had defined my family's response to my neurological crisis for 3 months. Dad continued his morning rounds in the emergency department, treating traumatic brain injuries with the expertise that had made him renowned in emergency medicine. Victoria performed complex cardiac surgeries requiring precision and life-or-death decision-making. Mom managed critical care protocols for patients whose lives depended on immediate recognition of subtle symptoms. Yet none of them had opened the emails from Dr. Sarah Martinez, the neurosurgeon who'd been trying to schedule my emergency craniotomy for 2 weeks. "Emma, you need to stop calling me at work about medical appointments," Victoria said during one of her brief phone calls home. "I'm in surgery 12 hours a day saving actual lives. I can't drop everything every time you have anxiety about routine follow-up visits." The routine follow-up visit she was dismissing was a pre-surgical consultation for removal of a 3.2 centimeter glioblastoma that had been growing in my frontal lobe for months. But explaining the urgency of brain tumor surgery to a cardiothoracic surgeon who'd already decided I was being dramatic seemed pointless. "Besides," she continued, "if this were genuinely serious, don't you think Dad would have noticed? He's been practicing emergency medicine for 25 years. He knows the difference between real medical emergencies and psychosomatic complaints." The irony that Dad's emergency medicine expertise somehow didn't extend to reading his own email or returning calls from neurosurgery colleagues was lost on Victoria. He'd been so focused on maintaining our family's reputation for medical excellence that he'd stopped applying medical judgment to situations that might complicate that narrative. "Your sister's right," Mom agreed during our weekly family dinner, where I'd been trying unsuccessfully to discuss my upcoming surgery. "You've been fixated on these medical appointments for months now. At some point, you need to trust that we understand healthcare better than you do and stop seeking attention through medical drama." The accusation that I was seeking attention through medical drama might have been hurtful if it weren't so absurdly disconnected from the reality of facing brain surgery alone while my medical family planned vacation schedules around dates that conflicted with my treatment timeline. "Emma," Dad added with the gentle authority he'd perfected through decades of calming anxious patients, "anxiety can manifest as very convincing physical symptoms. Your mother and I have discussed your situation with several colleagues, and we all agree that psychological intervention might be more appropriate than continued medical evaluation." The revelation that they'd been discussing my psychological condition with hospital colleagues while ignoring communications from neurosurgery made my stomach clench. They'd been undermining my credibility throughout the medical community while remaining completely ignorant of the actual medical emergency they were dismissing. "Dr. Peterson in psychiatry has offered to see you," Mom continued helpfully. "She specializes in anxiety disorders and could help you understand why you're interpreting normal medical experiences as crises." The suggestion that I needed psychiatric intervention for having brain tumor symptoms was so medically negligent that I found myself wondering if my family's professional licenses would survive the eventual revelation of their diagnostic failure. "What about the imaging results?" I asked quietly, making one final attempt to penetrate their willful ignorance. "Have any of you actually reviewed the MRI reports?" The silence that followed was telling. Dad's expression suggested he'd forgotten that imaging reports existed. Victoria looked genuinely confused about why MRI results would be relevant to what she'd characterized as anxiety symptoms. Mom's nursing expertise had somehow failed to extend to basic follow-up on diagnostic testing. "Sweetheart," Dad said finally, "if the imaging had shown anything concerning, we would have been contacted immediately. The fact that no one has called with urgent results proves that your symptoms aren't as serious as you've been imagining." What he didn't know was that urgent calls had been coming to his office daily for 2 weeks. Dr. Martinez had been trying to reach him about surgical scheduling. Dr. Morrison had left messages about immediate treatment needs. The hospital's tumor board had been waiting for family consultation about my case. But Dad's voicemail was full, his email was unmonitored. and his assumption that good news travels by silence had prevented him from learning that his daughter needed emergency brain surgery to survive. Tomorrow, his medical colleagues were going to provide some education about how urgent neurosurgical communications actually work. The St. Mary's Medical Center boardroom filled with the hospital's senior leadership as Dr. Margaret Torres, Chief Medical Officer, convened an emergency meeting about professional conduct and patient care standards. My family sat in the front row, summoned for what they believed was a routine administrative meeting about hospital protocols. "Thank you all for coming," Dr. Torres began, her voice carrying the gravity of someone who'd spent 30 years in hospital administration. "Today's discussion concerns a case that has raised serious questions about professional responsibility and family medical neglect among our senior staff." Behind her, the large presentation screen displayed the hospital's logo and the title, Case Review, Professional Negligence in Family Medical Care. Dad straightened his tie, assuming the presentation would focus on someone else's medical failure, while Victoria checked her phone for surgical schedule updates. Dr. Sarah Martinez, the hospital's chief of neurosurgery, approached the podium with the controlled authority of someone who'd spent 2 weeks trying unsuccessfully to contact family members about emergency surgery. The case involves a 31-year-old female patient diagnosed with glioblastoma multiforme, an aggressive brain tumor requiring immediate surgical intervention. She clicked to her first slide, my brain MRI showing the tumor that had been growing progressively larger over 3 months. The image was stark, unmistakable, a 3.2 centimeter mass with characteristics that any medical professional would recognize as immediately life-threatening. Dad's confident expression began to waver as he processed what he was seeing. Victoria's phone remained forgotten in her lap as she stared at imaging that her surgical training forced her to understand. Mom's nursing expertise activated late, but with devastating clarity. The patient, Dr. Martinez continued with clinical precision, sought medical attention for persistent headaches, cognitive changes, and seizure episodes beginning 3 months ago. Multiple specialists identified the tumor through standard diagnostic protocols and recommended immediate surgical intervention. She advanced to the next slide, a timeline showing my medical consultations, specialist referrals, and diagnostic testing that painted a picture of appropriate medical care progressing normally toward necessary treatment. However, Dr. Torres interjected, the patient's immediate family members, despite being senior medical professionals at this institution, systematically dismissed her symptoms as attention-seeking behavior and refused to participate in treatment planning. The third slide showed communication records. Voicemails from neurosurgery left unanswered, emails from oncology marked as unread, surgical scheduling requests ignored for 2 weeks. The pattern of medical negligence was documented with the thoroughness of a malpractice investigation. Dr. James Chin. Dr. Martinez addressed my father directly. You received 14 urgent communications about your daughter's emergency surgery scheduling. Dr. Victoria Chin. You were contacted multiple times about family consultation for complex neurosurgical planning. Dr. Linda Chin. Your nursing protocols require family involvement in patient care coordination. The silence in the boardroom was deafening as my family processed the magnitude of their medical failure. Dad's emergency medicine expertise had somehow failed to extend to recognizing brain tumor symptoms in his own daughter. Victoria's surgical precision had been irrelevant when applied to dismissing rather than treating medical emergencies. Mom's nursing care standards had disappeared when applied to family members. Dr. Torres delivered the final assessment. Medical professionals who ignore documented brain tumors in their own family members while maintaining licenses to treat strangers represent a danger to patient safety. Your professional conduct has fallen below acceptable standards for medical practice. The investigation that would determine their professional futures had already begun. 8 months later, I received my 6-month post-surgical MRI results showing complete tumor removal with no signs of recurrence. Dr. Martinez had successfully performed the craniotomy that my family had delayed by weeks through their medical negligence, and my neurological function had returned to normal. The headaches were gone, the seizures had stopped, and my cognitive abilities had fully recovered. Dad's license to practice emergency medicine had been suspended pending a comprehensive review of his decision-making capabilities. The medical board had determined that a physician who ignored urgent neurosurgical communications about his own daughter posed an unacceptable risk to patient safety. He was now working as a medical consultant for insurance companies, reviewing cases rather than treating patients. Victoria's surgical privileges had been restricted after the hospital board questioned her clinical judgment. Her colleagues couldn't reconcile her technical skill with her complete failure to recognize brain tumor symptoms in a family member. She transferred to a smaller hospital across town, where her reputation hadn't preceded her. Mom had lost her position as director of nursing when the state board reviewed her failure to apply basic nursing protocols to family medical situations. Her 15-year career managing critical care had ended when supervisors learned she'd dismissed emergency surgery as routine medical drama. They'd moved to a modest apartment downtown, their medical careers permanently damaged by their inability to apply professional expertise to personal situations. The respect they'd commanded in medical circles was replaced by cautionary tales about professional blind spots. I'd returned to my research position at the university's Neuropsychology Institute, where I now studied family dynamics in medical decision-making. My experience had become valuable data for understanding how medical professionals sometimes fail their own families while successfully treating strangers. The best medical advice I'd received was learning to distinguish between doctors who practiced medicine and doctors who simply performed it professionally.